Good evening, everybody, and welcome to Prostate Forum. We are serving Southern California and beyond. We are honored tonight for the first time to welcome Dr. Wayne Brisbane of UCLA Health. Dr. Brisbane is Dr. Brisbane is assistant professor at Westwood University, UCLA. He will be discussing something that we're all dreading and yet would like to see become simpler and more precise, and that's the future of prostate biopsies. He is, as I said, assistant professor of urology, UCLA Health, specializing in image-guided prostate biopsy, surgery, and focal therapy, of which I've had focal therapy, as many of you know. Medical training, Loma Linda University, right here in Southern California, residency in urology, and University of Washington. Completed urologic oncology fellowship at UCLA, and leads clinical and research diagnostic work, clinical and research work integrating micro-ultrasound, which we love to talk about, MRI, PSMA PET CT MRI, and dedicated to helping men choose the best treatments with the best balance of effectiveness and quality of life. Without further ado, Dr. Brisbane.
All right. So I'm at UCLA, and specifically this is kind of the UCLA story behind micro-ultrasound, and I'm excited to present some of our work in micro-ultrasound for optimization of biopsy, and specifically present the data from the Optimum Clinical Trial, which is a new clinical trial which we're very excited about, that compared micro-ultrasound to MRI for prostate biopsy. So I do have a couple of conflicts. Specifically, I receive funding from Exact Imaging, and then I'm very interested in running clinical trials, and so I have funding for clinical trials through several commercial interests, just so you know about that. So I want to tell the story behind the Optimum Clinical Trial, and it's kind of I think stories are easier to follow. Talk about what is micro-ultrasound, because I realize that might be a new phenomenon for many people. Talk about what it was like to run the Optimum Trial here, and then what are we doing with micro-ultrasound going forward. So this is a clinical trial that was just published in JAMA, and the lead author and myself were both fellows here at UCLA. And I actually was at University of Florida Health and UCLA. I transitioned halfway through this trial. And so I was one of the only people who enrolled at two different institutions. And so I got to see it firsthand from different places. But this is a clinical trial that was published in JAMA earlier this year, and it's micro-ultrasound guided versus MRI guided biopsy for prostate cancer diagnostics. So in 2019, I was actually a fellow. I was at the University of Washington, as Neil was mentioning, and I came down to UCLA, and I was very much planning to study bladder cancer, because that's what I thought was most interesting while I was a resident. And then Dr. Marks, who's actually presented to you all in the past, and his fellow, who is Adam Kennard, who was the first author on this Optimum trial, both convinced me to study prostate cancer. And so that was the start of my journey with prostate cancer, starting in 2019. Now, at UCLA at the time, we were studying exactly how prostate MRI could be correlated to the imaging findings could be correlated to the surgical findings. And so this was a setup that was developed by one of the engineers in our labs, where they put all these little sticks through, which created this very interesting point dot signature. So we could then create these hole mounts. And then when we sectioned these hole mounts, we would be able to co-localize the things that we found on the pathology with the imaging findings. And then the micro-ultrasound was kind of a new way of visualizing the prostate, and so we were very interested in seeing if we could also do this within micro-ultrasound. And so this was the fellowship team that I was with in 2020. Dr. Marks, as I mentioned, was our mentor right here. Alan Priester was the engineer who developed the thing you just talked about. This is me. And then I started working with a very brilliant postdoc named Jake Pensa, who was launching this project with me. Just a second. There we go. So this is what micro-ultrasound looks like. It's a specialized ultrasound that is rotated underneath the prostate. So here's the micro-ultrasound probe like this, and then it's rotated like this to acquire serial images. Here's some images that may or may not be familiar to you, but the pubis, the muscles that control the urethra called the levator ani. This is the prostate. This is a specialized fascia called the non-Vies fascia. And then this is the anal sphincter right here. And the anal sphincter is what's responsible for tightening the sphincter and causing fecal control. Now, this is the anatomy of a micro-ultrasound blown up and kind of fused together. So you have the pubis right here. You have the prostate going up towards the bladder right over here. You have the seminal vesicles that come in to the urethra, which is going down like that. And then this would be the viru. This is where the ejaculate pools right before emission. And so this is kind of the anatomy when we take a step back. Now, when you're comparing micro-ultrasound to MRI, I put micro-ultrasound here in panel A and an MRI in panel B. You can see that this is the exact same prostate. So I've outlined these ducts in green. So you can see these ducts. I've shown the urethra in yellow right here. And then you can see this cancer outlined right there and outlined right there. One of the things that's very interesting about this is the, I'm going to try and delete this one. One of the things you'll find that's very interesting about micro-ultrasound is that it has extremely high resolution, okay? So that's one of the mechanisms by which it visualizes things. And so you can see the resolution of MRI in panel B is actually considerably less than micro-ultrasound. Now, micro-ultrasound doesn't have the multiple parameters that MRI has, but the high resolution is what allows it to visualize the prostate cancer. And the main thing about resolution, so resolution is the ability to differentiate 2 points in space. Micro-ultrasound can differentiate 2 points in space on the order of 70 microns. So between 2 points in space, those 2 points in space can be as close together as 70 microns, which is very close, versus conventional ultrasound, which is normal ultrasound you'd get if you were looking at, a baby or looking at your gallbladder or kidney. That can only differentiate 2 points in space of 200 microns. And this becomes very important within prostate cancer because the mechanism of prostate cancer, you can see this, my little cartoon over here, is this Gleason score, right? The Gleason score is how we characterize prostate cancer aggressiveness. Gleason scores of 1 are perfectly normal ducts, and you can see these 2 points differentiating those 2 points. Those 2 points, as I've shown on a normal duct here, are about 500 microns. Okay, but as you get into these cancer-filled ducts are around 90 microns. So the ability to visualize these two structures as separate rather than together is the difference in visualization of normal ducts and cancer tissue. And so that's the mechanism by which micro-ultrasound appears to work. And this has been classified. I know maybe not everyone's familiar with this, but if you've heard of prostate MRI, and I'm imagining this cohort of individuals we have tonight are pretty up on the research with prostate cancer. So you'll have heard of prostate MRI, and then MRI has a specialized scoring system that we call PI-RADS. And PI-RADS helps us delineate a normal MRI from a concerning MRI, and we give the scores as it becomes more concerning, 1, 2, 3, 4, and 5. Micro-ultrasound also has something, but we call it PRI-MUS. This is a very close analogy, but it uses acoustic features, and specifically acoustic features where we're looking at these big open ducts on the micro-ultrasound. You can see them there. Some smaller ducts right here, okay? The lack of ducts, and then the internal shadowing where we see no ducts versus this very dark area right here where we see no ducts and the tissue is so dense that it starts to send cascading shadows behind it. And that's the PRI-MUS scale that we use for micro-ultrasound. Now, micro-ultrasound, we were taking in, and as part of this research, we were taking these patients who had surgery and we were correlating how well the micro-ultrasound could visualize the tumor versus the MRI, and we're using surgical pathology as a ground truth. And so this is an example of somebody who got a surgery, and then we would take their we take their pathology, so this is their prostate that has come out. We would put it in one of those specialized molds that was developed by Dr. Priester at the beginning of our talk, and we would scan their prostate. So this is a robotic arm that would translate the micro-ultrasound arm this direction, and we'd be able to scan the prostate and visualize all the structures internally, and then we could correlate those structures back to the actual surgical pathology in order to see how accurate micro-ultrasound was compared to MRI. And so this is a nice picture of one of those resections where you can see conventional ultrasound. This is the stuff, again, that you'd have if you were looking at a kidney or a baby, versus the resolution you're getting with micro-ultrasound. And this is just a nice visual representation of what you're getting with this really, really high resolution ultrasound. And there's these characteristics, and I just showed you this briefly, but you can kind of see that this darkness, this lack of ductal architecture, this is what we call a mottled appearance, and it's correlated as a PRI-MUS 4, and this indeed is some 4+3 prostate cancer. But interestingly enough, on conventional ultrasound, this area doesn't look that much different than this area. Now, Dr. Priester, who is the PhD, was very productive, so he created a system for co-registration of those high-resolution ultrasounds, magnetic resonance imaging, and whole map pathology. That was that little box where the prostate sat in that little mold that was clear, and we translated it. So he published that in an engineering journal. We also published some of our work using prostate micro-ultrasound detection and registration, and then we also did some artificial intelligence, which was this was not quite, this was an anterior one, and then we did some deep learning classification. So this was a huge project that took several years and resulted in Dr. Pensa receiving his PhD. The thing that we also were talking about at the beginning of this talk was the Optimum Clinical Trial. And actually the Optimum Clinical Trial had a lot of its roots here at UCLA. And so Leonard Marks was one of the initial authors on the contemporary clinical trial design paper, where we talked about this is what we're planning to do. And I remember sitting with Dr. Marks. I was his fellow, and so this is his 21st birthday, as you might expect. And so we were chatting. He helped develop this clinical trial, and so it was a huge honor for me in order to get to participate at both the University of Florida and UCLA in actually enrolling patients. So let me slow down for a quick moment and show you what the design of this clinical trial was that was eventually published in JAMA. So there was 3 groups in this design. Group 1 was micro-ultrasound images, where there's the micro-ultrasound. Group 2 was micro-ultrasound with an MRI on top of it. So group 1 was micro-ultrasound alone. Group 2 was micro-ultrasound plus an MRI, and you can kind of see this picture-in-picture up here. So the MRI gave us a clue. And basically what we would do is first, we would look at the micro-ultrasound and we would biopsy any targets that we saw, and then we would get unblinded and we'd see what the MRI saw. So group 1, only the micro-ultrasound, no MRI. Group 2, micro-ultrasound where we were blinded to the MRI, took our micro-ultrasound targeted biopsy, and then looked at the MRI. And group 3 was micro-ultrasound wasn't involved at all. It was MRI targeted biopsy. And I think Dr. Marks, when he previously chatted with you, talked about that kind of with something like the UroNav or Artemis or Coelis. This is where we take a line around the prostate and we kind of fuse it to the MRI, and then the artificial cartoon of where the target is used to guide the urologist. So the main arm was micro-ultrasound alone, micro-ultrasound, then unblinded to MRI, versus the MRI kind of conventional standard of care. And we randomized men to receive 50-50 between micro-ultrasound guidance and MRI guidance. So this is the trial design, just saying men who had an elevated PSA or abnormal DRE, no prior biopsy, and no prior MRI, they got randomized to a biopsy arm, group 1, 2, or 3, and then they got a biopsy. And this is kind of mirroring what you might see in practice, where guys have some reason to get a biopsy, and then they get an MRI-guided biopsy. And so we're seeing, how does micro-ultrasound compare to MRI when introduced into this framework? So in 2001, as I mentioned, I went from UCLA to the University of Florida. This is me finally graduating. And that's the little bear that I got. This is the bear in Florida once I became a Gator fan and my staff dressed it up with the Georgia-Florida game. And so I was there, and my wish list, was to do micro-ultrasound research. And so my chair there got us a micro-ultrasound, and we were able to start doing micro-ultrasound. This is one of my first patients. He actually then went online and disclosed that, he was a patient, so this is not a HIPAA violation, really lovely guy. But we started doing prostate biopsies and using micro-ultrasound to help us guide those prostate biopsies. And then in 2023, I actually got an offer back from UCLA. I wasn't expecting this. The University of Florida was going very, very well, but a job opened up, and my mentor, Dr. Leonard Marks, said, I'd really like to have you come back, and part of the ask was to run this clinical trial called Optimum, which I was excited to do. So it went from a Gator to a Bruin fan. And this is going back through UCLA and saying, we wrote this at the IUO, and this is the Institute of Urologic Oncology. One of the cool things about UCLA is the research that we did, but it was a really cool thing to be a part of this at two different institutions. And so the primary outcome, this is the figure 2 within our paper, and what we're showing you is this first question, the primary outcome. A way of saying it is, can micro-ultrasound alone replace MRI? Okay, that was the question it was trying to answer. The secondary outcome was trying to say, is micro-ultrasound with MRI fusion as good as conventional MRI to ultrasound fusion? So you can see these two questions as they pop up. First question, can micro-ultrasound guidance replace MRI? And second, is micro-ultrasound MRI fusion as good as MRI ultrasound fusion? And so basically we said this was a non-inferiority design. So we said there's no difference at 0. And we said as long as the difference is not less than 10%, it's not 10%, we are going to deem this to be non-inferior. Okay? And what we found was very interesting, actually, on our primary analysis saying who found more cancer. Micro-ultrasound, they were equivalent, but micro-ultrasound was even trending towards favoring micro-ultrasound. So this is favors micro-ultrasound, this is favors MRI. So equivalent, as long as this line crosses the 0, then it's not better or worse, but it is trending towards favoring micro-ultrasound. And when we look at the secondary outcome, is micro-ultrasound MRI fusion as good as MRI ultrasound fusion? That also trended towards favoring micro-ultrasound, so giving us some very, very strong understanding that micro-ultrasound was non-inferior to MRI for cancer detection. We also did a per protocol analysis, meaning the primary analysis was which one you were randomized to. The per protocol was actually what you received, and that was also similar. And then when we look at micro-ultrasound versus MRI guided biopsy, we find that these are the grade group 2 detection. So micro-ultrasound found half of the grade group 2s. This was the overall detection. Sorry, I got to sneeze. Excuse me. This is the overall detection. So half of the patients in the micro-ultrasound arm had grade group 2 detection versus 47% in the micro-ultrasound and MRI arm versus 43% in the conventional ultrasound versus MRI arm, showing that this is a non-inferiority test, showing that was significant. And the same thing for grade group 3. Like, these are much more aggressive cancers. It's equal detection rates in all 3 arms. Now, the other thing that's interesting is the health economic impact. Okay, so when we look at the MRI arm, we can say, the cancer detection arms are very similar, but there's radiologist time and MRI time and biopsy time that we need to factor in for the health economic impact. And this can be very important, obviously, as we're all taxpayers and trying to think of how do we save money. And there was basically an absolute increase in clinically significant prostate cancer within the micro-ultrasound arm. You obviously have MRI and radiologist savings, and it's slightly faster. I would say probably equivalent if you were to use 0.6 minutes, probably doesn't matter that much. But that does equal about, this is the savings. So the MRI pelvis is about $361 when we charge Medicare, and then $81 for the fusion guidance. And so there's about $445 per case that you're saving when you do a micro-ultrasound guided biopsy. The clinical translation stuff, this is stuff that's been happening in my lab that I think is really interesting. So these implications, is micro-ultrasound or MRI better to guide biopsy if both are available? 4% increase in grade group 2 detection with combination. So I do, in my practice, use both of them. And then this is something where we showed that if you do dual imaging positive images, so dual imaging positive meaning that if both cancers are detected by the images, you actually can avoid doing systematic. So instead of multiple cores, you just do 3 cores, and that is nice as far as making the morbidity of a biopsy less significant. And this is one of the students working in my lab named Dan Luca. We're very excited about him. We're hoping that he will come to UCLA. When we looked at the PRI-MUS and PI-RADS scores, this was the accuracy. We found that both of them were fairly significant, though I do think that the PRI-MUS score is a little less mature. So you can see nicely that the PI-RADS score, if I can find my cursor here, the PI-RADS score has this nice stair step to it. So each score goes up 1, 2, 3, and you get more and more cancer detection, where the PRI-MUS score kind of is similar in 2 and 3, and then there's a big step between 4 and 5. So that's another project that Dan Luca has been working on, trying to help improve this PRI-MUS score. And there's several limitations. This is to the clinical trial in overall. So systematic biopsy may mask imaging failures. Targeted biopsies. When we looked at stratifying men between MRI and micro-ultrasound and the targeted biopsies, they were equivalent. It was an open label design, meaning that people could cheat if they wanted to and look at the MRI in that arm too. But we did backwards checking to make sure that there was no captured images and found that there was no cheating, at least that we could find out. The MRI convention fusion was not standardized, meaning we kind of said whatever you're used to, you should use that. And it was a biopsy naive population, so it's hard to convert this into an active surveillance population. So in conclusion, micro-ultrasound is an attractive option for guiding prostate biopsy with or without MRI. It does save about $450 per case. And it may have applications in active surveillance. We may be using it to help us find lesions. There's AI integration and possible radiomics. So thanks so much for your attention. That's an overview of kind of this fairly large clinical trial published in JAMA earlier this year that we're very excited about here.
Outstanding. Thank you very much, Doctor, for joining us. And the micro-ultrasound is something we're particularly excited about here, because some of us are a little claustrophobic and it takes a little bit of Valium to get to and from. And also we realize there's a lot of pressure on radiology departments to use MRIs for all kinds of things, including emergency cases. So we're looking at micro-ultrasound as a means of potentially decongesting backlogs for all kinds of patients using that, and office procedures. We have 2 clinics in the Southern California area that have been using colored Doppler for years. And we're looking forward to color Doppler being upgraded by micro-ultrasound, and other urologists and other clinics picking this up as a good, fast, inexpensive, accurate strategy for diagnosing prostate cancer. Well, I think what we want to do is unmute and play Hollywood Squares here. Dr. Metzger is with us, but he's lost his voice. But he has a question. And the question is, since ultrasounds are hard enough to interpret for an experienced radiologist, how will a practicing urologist with little training interpret the new scan? And this is, again, going not only to micro-ultrasound, but maybe at some point the overlay of artificial intelligence in reading micro-ultrasound.
Yeah, no, I think it's a very, very good critique. We did look at inter-reader variability and found some significant differences among urologists who are interpreting the same micro-ultrasound scans. So that is a concern. And we're attacking it in the old-fashioned way and in the up-and-coming way. So the old-fashioned way is we're running, master classes and providing certification for urologists to make sure that they're understanding or have reached certain levels of training. So that's one way, and that's, just how you learn anything. And then we're also obviously pursuing an AI solution, which will take some time, but it's what we're working on.
Excellent. For those of you new to Prostate Forum, we have a panel of highly experienced patients, educators, and professionals. So we're going to go to our next well-versed patient and volunteer here with Prostate Forum. Ira, how are you doing tonight? And what questions do you have
Good evening.
for the doctor?
Thank you, doctor, for the micro ultrasound is a great thing. Could you talk about the PSMA in conjunction with that?
Yeah, of course. PSMA is a new whole body scan, and it's a very different mechanism of action, but it's a very good staging scan, and we're very excited about it. We do have a paper it's under review at Radiology, which is comparing all three modalities. And the answer is for identifying cancer within the prostate, it seems that micro-ultrasound, MRI, and PSMA are equivalent. And so that was the question we asked. No one will argue that PSMA is far superior for looking at cancer anywhere else in the body.
So do you do PSMA in conjunction with the micro?
We do have a clinical trial that is asking that question. Can we do PSMA before a biopsy? Currently, that's limited by insurance companies refunding it. So right now, if you wanted a PSMA scan, you have to have a biopsy already or have to have a diagnosis of prostate cancer already. So we have two clinical trials open where we're trying to see if we can get the PSMAs before the biopsy, one in the biopsy naive setting and one in the active surveillance setting. So if anyone's interested in those clinical trials and qualifies, we have them open. But we're trying to see what is the additive benefit of PSMA in these certain clinical scenarios.
Thank you.
Outstanding. Thank you. Craig, welcome. Thanks for joining us here. How are you tonight?
I'm doing just fine. Thank you very much.
Oh, go ahead.
You have a question for the doctor.
Oh, I'm sorry. Do we have two Craigs?
Craig, yeah, you're Craig Foy, and you're at the top of my list right now to ask
okay.
if you have questions.
All right. So the question was no, I'm just sitting. This is all completely over my head, and I'm just kind of following along. Okay, but thank you so much. It's been very interesting. And I appreciate listening in on this.
Our pleasure. Francis, thank you for joining us. Welcome back.
Thanks, Neil. Glad to be back. Hi, Dr. Brisbane. Nice to see you again.
Good to see you, Francis.
Can you talk a little bit about what was one of the situations that came up when you did my micro? Can you tell when a 3-4 has become a 4-3? Is that degree of clarity available to you?
The answer is probably not. I think that perhaps with some machine learning algorithms, we could get into teasing that out. But I constantly find that I'm making mistakes when I try to make that level of granular decision and granular predictions. So I do think that we can put things into buckets of not too bad, moderately bad, and really bad. So I can usually kind of get there. But to get the really fine granularity of percentage pattern 4, I don't think we're quite there yet.
Thank you. Then I guess my observation is you probably want to do guys who are naive to any sort of prior testing. Is that your basic approach?
Yeah, so currently we have obviously this just standard of care clinical trial or clinical treatment open. So people who are just saying, hey, I need biopsies for whatever. And then we have some clinical trials where we're asking specific questions. And so we do have the Optimum Trial already fully enrolled for the biopsy naive. And the next cohort we're asking a question in is guys who are on active surveillance. And so we're trying to see, does micro-ultrasound do as good a job as finding the cancers? And then another question that's a little harder to answer, but also worth asking is, can you, as you mentioned, use micro-ultrasound to decide, do men need a biopsy? So instead of going in and taking a sample, can we just scan the prostate and see, has it transformed, yes or no? And that's not a clinical trial that we have open quite yet, but it's one that I'm interested in developing.
And that's the setting in which you would then do maybe 3 needles instead of 12? Is that what you're referring to?
Yes. And so we're also developing that trial where we're trying to see, can the biopsy strategy be de-intensified? Do we need to do all these systematic biopsies now that we see these lesions so well? do we need to put needles everywhere? And my hypothesis is that you don't need to, but that should really be proven, because what you don't want to do is be very confident and say, oh, look, we're doing, we can easily find all the cancers, and then miss something important. And that's definitely happened if you don't really test your hypotheses.
Thanks. And again, it's a pleasure to see you. And welcome back. I don't know what UW is doing, but they're okay.
Yeah, of course.
Paul, how are you doing tonight? I see you in blue screen today.
I'm here. I have a blue screen, so I don't have to look at myself in the screen. I have several questions for the doctor, and I really appreciate him coming and presenting it to us.
Of course.
First, a very basic question. The micro-ultrasound, how is that given? Is that like an MRI where you sit on a table and a machine moves over you, or is it like a transperineal where a needle is stuck through you?
It's like an ultrasound in the rectum. So it goes in, you scan the prostate, and so it feels like an ultrasound in the rectum. That's how it is.
Okay. My second question is a general question on biopsies. My primary physician said that biopsies can result in cancer cells being freed from the prostate tumor and going into the rest of the body and leading to spread of cancer, which otherwise would not have happened had you not had the biopsy. He said that Europe recognizes this, and for that reason, they don't do biopsies. Is there any truth to this?
That I think it is. I have a difference of opinion from the primary care doctor, and I also think that he might be misinformed, or she might be misinformed on the European guidelines, because definitely the European Urology Association is very pro biopsy. They're very pro imaging as well, and I think the more important thing is that you should do imaging prior to a biopsy to decide, do you really need it, yes or no. There's been about 22 cases of cancer spreading along biopsy tracts, and that's out of almost 20 million cases of biopsies. So probably a few haven't been reported. So it's not 0%, but it's pretty much close to 0%. And so I just think that's not a founded argument.
Great, thank you. And my last question is, I've had a hip replacement, and I need a second one. And on my MRI and the other one, the results came back and said that, the viewing the biopsy was somewhat limited because of the hip replacement, the metal. And the urologist I went to said I should definitely not get the second hip replacement because that would even obscure future MRIs in the future. And then somebody here on the panel has said that the micro-ultrasound does not suffer from this limitation. Is that correct?
That's correct. Yeah, that's the main benefit of the micro-ultrasound, is it's not impacted by ferromagnetic implants.
Okay, great. Well, thank you. Very good answers. I really appreciate it very much.
Of course. I will note, Neil, that Thursday night is date night, and so I do have to go at some point because my wife is reminding me of this.
I show 5:44 on my clock.
That's
Should we
true.
wrap up by 6?
If we could do it by 5:50, you would make my matrimonial life better.
Okay. I've got a question from Bob, and then I'm going to ask everybody to please either raise your hand or open your screen and raise your hand so we can expedite. Bob, what is your question?
Real quick, for different scenario in recurrence, post-surgery, down the road, with a negative PSMA PET CT, is there any role for micro ultrasound in the abdominal area or the pelvic floor area?
Yeah, good question, Bob. There is a group that has published on this, and I'm very skeptical of their results. So it's just not as good at looking in there, and I just don't know what they were looking at when they published these results. I reviewed their paper, and I really do think in that scenario, PSMA remains the gold standard.
Okay, thank you.
Fellow HIFU patient Limano has a question. I hope I pronounced your name right. Go ahead, Limano.
Yeah. Hi, Dr. Brisbane. I wanted
Hey,
to
how are you? Good to
pretty
see you.
good. You too. Hey, thanks for the presentation. I wanted to thank you for the second opinion last year.
Of course.
Enjoy your date night.
Thank you, my friend.
All right.
Searching now for raised hands. Steve, do you have anything for us? Question? I got Steve K and I have another Steve.
I have a
Anything
question.
here? Thank
Um,
you, Steve K.
so I just recently had an MRI that identifies no, my PSA score is up driving the MRI. The MRI didn't find anything in the prostate. And so I am booked December 2 for just a general journey through the prostate. Let's go grab 12 samples.
Yeah.
Should I, in effect, push that back and get a micro ultrasound so things are smarter?
Yeah, it's a great question. I'm highly biased. I do think that that is a slightly more accurate approach. And we are able to look for more cellular density on micro-ultrasound and try and sample those areas preferentially. So, but that question has yet to be answered, though it's a good question. And specifically, men who have high risk for, some kind of elevated PSA, but negative imaging, where does micro-ultrasound play a role?
Right.
We're about to publish a paper that shows PSMA might play a role, but PSMA is very difficult to obtain currently, where micro-ultrasound is pretty cheap and easy. So it's a very good question.
And is there a micro ultrasound available in Orange County where
It sure
we're
is.
located?
Yeah, so Jeff Bassett at Hogue does them and is quite good at them. And then there is one also at University of San Diego with Juan Javier Deslages.
Okay, thanks for the guidance.
Absolutely.
Any other questions, gentlemen? Do I have any unmutes, raised hands, anybody?
Thanks so much for the opportunity. Really appreciate it.
Doctor, thank you for joining us. You're certainly welcome to sign off, and I'll have a few things to say to the audience.
Thanks, Dr. Brisbane.
Absolutely.
Before we end the meeting tonight.
Thanks again. I have a good one. Bye.
Thank you.
Thank you.
Gentlemen, this is giving season here at Prostate Forum. Some of you will receive our letter in the mail asking you to contribute. Even a $5 check is great for us. You are welcome to give through PayPal. You will be seeing Thanksgiving time and Christmas time an invitation to support our organization. We also accept minimum distributions of IRAs, which your tax preparer could contact us about, or your accountant can contact us about. And we're also accepting car donations, and you'll see a link to donate cars, trucks, real property, stuff like that. We will be with you during the holidays. One of the neat little innovations that started about 3-4 years ago is that we will be meeting for support during December, which didn't used to be. So second and fourth Tuesday nights, 5 p.m. Watch your emails. If you are watching this at home on YouTube, please sign up at prostateforum.org, and look for the link to sign up for our emails. In the meantime, have a great Thanksgiving, and we look forward to seeing you second and fourth Tuesdays. This is our last presentation for 2025. Watch for new presentations in 2026. In the meantime, enjoy your dinner, and we look forward to seeing you on the second and fourth Tuesday.